And would like now to go for session 7, the dislodgement of the stent. The chairman will be Dr. Fawaz al-Mtairi.
Okay, we'll go to our next session, the dislodgement of a stent. It's my pleasure to have with me as a panelist Dr. Hamid Al-Ghamdi, Dr. Amr Al-Hadidi, and also Dr. Ahmed Khashab and Dr. Badr Zahrani, but unfortunately they didn't come. So maybe I'll invite Dr. Ra'id Al-Qadshan to be one of our panelists, kindly. And we'll go with our first presentation. Dr. Jogi George from USA is an interventional cardiologist, internist cardiologist, advanced heart failure, and transplant cardiologist. He will talk to us about stent, dislodgement tools, and techniques.
Good morning, everybody. Thank you for the invitation to present at this conference. I would like to thank especially the course directors. My name is Jogi K. George. I am an interventional cardiologist and an advanced heart failure transplant specialist at Texas Heart Institute. We're going to be discussing tools and techniques that we have available for coronary stent dislodgement. And we're going to start with a case, and we're going to discuss some tools and techniques that we have available to try to alleviate this complication. We'll get started. We're going to start with a clinical case. This is a gentleman, he's an 80-year-old male who has a past medical history of coronary disease. 3 years prior to this presentation, he had a STEMI in which he required primary PCI of his proximal left anterior descending artery. He now comes in with new onset chest discomfort typical for angina. His cardiac biomarkers and EKG were reassuring, so a stress test, a PET myocardial perfusion imaging was performed, which demonstrated he had a large reversible anterior wall defect, which was concerning for either instant restenosis or a new left main or proximal LAD stenosis. So coronary angiography was pursued, and we're going to review the angiograms. This is part of the diagnostic angiograms. And as you can see, this demonstrates that he does indeed have pretty severe instant restenosis of the proximal LAD stent. we're looking at different images of the same picture, or of the same segment of the artery here. Once again, we have a subtotal stenosis of the proximal LAD stent here. The rest of the vessel appears to be relatively unaffected, and there was no new circumflex disease. The right coronary artery was also imaged and did not have any substantial disease. So in view of this, the plan was to perform drug-eluting stent placement of that area to treat this lesion. So the lesion was wired with the choice floppy wire, which at our institution is our workhorse wire. And then the initial attempts to balloon this lesion had some difficulty, as the first balloon that was used would not cross the lesion. And then a smaller 1.2 millimeter times 8 millimeter balloon was then used with good results. And thereafter, the balloon was then escalated to a 2 millimeter by 12 millimeter balloon, which was able to cross the lesion without difficulty. And then the angiography thereafter demonstrated adequate results. So this is after balloon angioplasty of the lesion with a 2 by 12 millimeter balloon, with the compliant balloon, nevertheless. And as you can see, we have good results of the treated vessel segment. So thereafter, the decision was then made to stent, as this was a instant restenosis of a previously stented vessel. The decision was to re-stent with another drug-eluting stent, and based on previous data as well as angiographic data now, decision was made to use a 3 millimeter by 28 millimeter drug-eluting stent, which was able to cross the lesion relatively easily, and the stent was deployed at nominal pressures. And we will review the angiogram before and after the stent deployment now. On the left, we're looking at the operators placing the stent. As the proximal area of the stent was unaffected, the stent kind of straddles the previous stent with some distal coverage of the vessel as well. And this, on the right side of the screen, is of course the stent being deployed at nominal pressures. And this is the angiogram immediately after stent deployment, with the wire still in place. And as we can see, we have no flow pattern immediately distal to the third diagonal branch, and a little bit distant to the new distal edge of the stented area. So given that, there was concern for thrombus embolization in this scenario, the operators decided to treat this with antithrombotic agents, including 2B3A infusions, as well as copious amounts of intracoronary nitroglycerin, nicardipine, and adenosine. With these treatments, there was improvement in the vascular appearance, and after there was some improvement, they used intravascular ultrasound that demonstrated absence of dissection or thrombus, but it was a small caliber distal vessel, which would make any sort of interventions very difficult. So as there was persistent lack of reflow in this area, the operators decided to perform angioplasty with a 2 by 20 millimeter compliant balloon throughout the segment with some improvement. And this shows the angiogram thereafter. So we'll replay this a couple of times. As we can note, there is improvement distally. There is, to me, 2-3 flow distal to that area of the stent, but there is concern. There is this discrete lesion beyond the third diagonal branch that looks like there may be a thrombotic lesion or some sort of obstructive lesion there. And the operators were concerned about that. And the decision was made to stent that area with a small 2 millimeter by 12 millimeter stent. And this, of course, was in the absence of IVUS data, because by the time this angiogram was taken, this was after IVUS was obtained, and there was concern that perhaps there was new in situ thrombosis of that vessel. So the decision was made to treat with a 2 by 12 millimeter stent, but while the stent was placed across the lesion, there was concern that the stent would not cover the lesion. So a slightly longer stent, a 2 by 18 millimeter stent, was attempted to be used. But the operators found out that although the stent appeared to go beyond into the previously placed LAD stent, it was unable to be advanced. So they took both the stents, the longer stent, the 2 by 18 millimeter stent, was also removed. And this, at that time, with this difficulty, they examined the stent delivery balloons, and it was noted that neither stent delivery balloon had the stent crimped on it. So this, of course, was very concerning to the operators. And then upon looking at the angiograms and looking at non-contrast images of the intervened area, this was demonstrated that both stents, both the 2 by 12 millimeter stent as well as the 2 by 18 millimeter stent, was adherent to the previously placed LAD stent. And by this time, unfortunately, the guide wire was also removed, and there was concern. There was the only way to get this out was using snaring techniques. It was thought to be the operator's hands. The operators used a micro snare to retrieve these stents. In these pictures, I will point out where these stents are. You can see one of them there, and with embolization around into the distal area. So the operators used a micro snare to remove these stents back into the guiding catheter, and they were able to retrieve both dislodged stents. Angiogram thereafter demonstrated adequate results. So this is the actual snaring of the more proximal stent coming out there. And on the right side of the screen, we can see the post results. So these are the final angiographic results, which demonstrates adequate results. That area that was thought to be an occlusive lesion is now fully patent and did not require any further interventions. Now on the left, we can see the operators snaring the dislodged stent back into the guiding catheter. And these are the retrieved stents in the side table. As far as the patient was concerned, he did well. He was asymptomatic. The procedure was quite prolonged, and he was discharged home the next day without issues. So let's now discuss some of the techniques and tools that we have in the setting, how we make decisions with regard to what the best technique is. So as ways of introduction, we're going to see what kind of risk factors there are for stent dislodgement. And then depending on how the anatomy of the vessel is, and how much the stent is dislodged, we can employ specific tools to try to salvage the situation. So we're going to divide this into either partial stent dislodgement, which means that the balloon is usually within the stent, as well as the guide wire is also unaffected. Then we're going to discuss total stent dislodgement, but with the guide wire in place. And then we're going to discuss, as in this case, total stent and guide wire loss, which is, of course, the highest risk scenario and the most complicated to salvage. As far as invasive introduction, this is a rare, thankfully, this happens in less than 1% of PCI cases since the introduction of factory crimping of coronary stents. As we can imagine, this may result in death or emergent need for cardiac surgery as a displaced stent can cause complete vessel closure. And all these salvage techniques that we are discussing are not scientifically validated. These are all based on operator reported or case reports or case series. The key principle is retrieval into the guiding catheter and subsequent removal from the body if possible. If not possible, then we can try to either crush the stent into the wall or somehow displace it into an area that is least harmful. Maintenance of guide wire placement is key. As we discussed, most of the techniques that we rely upon is the guide wire placement is key to getting the dislodged stent out. Risks, as far as this is concerned, anatomical risks, that's patient risks, include severe calcification of the vessel, instant restenosis requiring redo intervention, angulation and tortuosity of the vessel that can cause the crimped stent to come off the balloon, and long diffuse disease is of course a risk. Technical risks include inadequate lesion preparation or debulking of specially calcified vessels. High pressure deployment in certain areas may cause this. And of course, size mismatch of subselective instrumentation is also an issue. So in this case, instant restenosis was, of course, an issue. And the subtotal nature of the lesion was also an issue. And presumably the gentleman had calcified disease distally, that of course played a role in the left main. So as far as partial stent dislodgement, the techniques that we use, if the balloon is still able to be moved independent of the stent, and the balloon can be advanced slightly, maybe a third of the way beyond the stent, and we can inflate it at a low pressure, maybe about 3 atmospheres beyond the stent strut, which will anchor the stent onto the balloon, which can then be retrieved back into the guiding catheter. If this is unable to be done, then a new smaller balloon, so we would recommend a single marker 1.2 or 1.5 millimeter balloon, which would be smaller than most of the mounted balloons that these stents come on. Use the guide wire to, of course, the guide wire that is still in place, to advance a smaller balloon distal to the vessel. Again, inflate it to about 3 atmospheres, anchor the uninflated stent, and get it back into the guiding catheter. If it's unable to get the stent or the balloon back into the guiding catheter, we can try to remove it en bloc with partial inflation with the wire still in place, and this should be stable enough to get the subselective instruments out of the blood vessel. So if we have a situation where there is total stent loss, but the guide wire is still in place, we can use, if the stent vessel sizing is acceptable, we can try to use this to deploy the vessel in the area that is displaced and try to salvage the situation. So again, this we would use a smaller balloon to try to recross it, and then try to salvage the situation by deploying the stent there. In case that there is a stent vessel mismatch, in other words, let's say if the stent is too small to cover the area where this is placed, then we can use a partially inflated balloon, a smaller balloon, to use this as a proximal anchor to push the undeployed stent into an area where there would be adequate size match of the stent. So both of these can be used where we have guide wire still in place, but there is total stent loss. In other words, there's no balloon in place, but the guide wire is in place. Even in this case, we can use a snaring device to snare the stent out, of course. Multi-wire technique, allowing the wire to sort of entangle itself with the previously placed wire, is a tool that can be used, although not as recommended, because it's a more unpredictable technique to use, and we may get the stent malformed in a way that it's unable to come out of the guiding catheter through the guiding catheter. In cases of where there is total stent and guide wire loss, snaring techniques as we used in the case that we discussed can be used. A couple of points to keep in mind is it's important to have the guiding catheter as coaxially as possible to allow the stent to be snared into the guiding catheter with least amount of trauma to the more proximal vessels, especially the left main. In cases that it cannot be stented, and if the vessel's size, the vessel caliber is large enough, the undeployed stent can be crushed to the vessel wall with a new stent that's presumably well matched to the caliber of the vessel. It's very important to check the stent and balloon for integrity once removed to assure a lack of fragmentation of the stent or the balloon catheter is used. And this also, of course, includes the wire, because these are high-risk situations where we are risking wire displacement or wire fragmentation. Thank you very much for allowing me to present. We will have some time to take some questions. Once again, I'd like to thank the course directors for inviting me to present. Thank you.
Thank you very much, Dr. George. It's a great presentation and great overview over the risk and the approach toward the stent dislodgement. Dear panelist, any question?
Yeah, I think he's not with us. Yeah? So I'm asking about, I'm telling you that the important point in this scenario, keep the wire inside the stent. This is the best scenario because you have an access to this stent to get it and come it back inside the guiding. The point is, when you have the size of the vessel, this is very important. If the size of the vessel is big, you can crush it. If the size of the vessel is not big, you can push it distally in one of the branches, as we saw. And this is very important because sometimes you cannot snare, sometimes you destroy a lot of things to get it back. Also, multi-wire technique is a good option. Thank you.
When it comes to complication, we always say that prevention is the best. And I do believe that any one of us who had complication, probably he had probably a feeling that something's going to happen. But we keep pushing just to finish the case. And that's actually when disaster happened. Now, in this case, obviously, probably the proximal stent was not well inflated. That's why they had 2 stents dislodged. So I guess the importance is the balance of prevention earlier on, anticipation, anticipation, anticipation. Now, personally, I have issue with some of the techniques because, you know, when you lose a balloon that gives integrity and support for the stent, especially when you have long stent, that you could not advance it. Getting a balloon, inflating it proximal to the stent and pushing it, you should be extremely careful because actually it might cause deformity of the stent. And when to stop? I mean, anyone can probably try it, okay? But when you stop before causing more damage. You know, as Dr. Hadidi said, you know, the size of the vessel plays an important role. But personally, when I run into such situation, with luckily few, I prefer crushing the stent. If I have a forgiving size of the vessel, that's probably the best. Second to snaring if I have an issue. Now, one of the other issues that oftentimes we oversee is when you try to fix it, okay, with manipulation, we tend to lose focus of the proximal catheter. And that's when sometimes actually we might cause damage to left main or RCA in these situations. Should I just like to draw your attention to this fact?
Dr. Raed, any comment? Okay. Any question or comment from the audience? Yeah, Dr. Abdurrahman.
Abdurrahman, while you come for your question, ask, anyone of you have ever tried inflating balloon proximal to the stent and pushing it further distal? Did it work?
You want to answer that?
Not inflating the balloon proximal to the stent. This technique I presented in EuroPCR, balloon push technique. I advanced the balloon to the proximal half of the stent, then inflated to low atmospheric pressure, around 4 to 6, then pushing the stent to the pre-planned place, then advancing after that the balloon, after inflation, then inflating the stent.
Interesting. Dr. Abdurrahman.
I think there is a clear distinction between trying to retrieve a stent in a straight pathway in an LAD, for example, compared to a 90-degree curved LCX. I've seen cases where people did more damage by trying to retrieve a stent from an LCX, and I think if they tried to push or crush, even if it's not size match, they would have done better than trying to retrieve it. So left main has been dissected, massacred for in hope to retrieve a 2.5 stents. So I think what's being shown there is applicable, but it's also different based on the type of artery you're dealing with. So I would say if you're in a straight pathway, it's always easier to deal with. I've tried snaring before, and I think people talk about it like it's something easy, and it's not. And you waste a lot of time trying to do that. Thank you.
Excellent. Thank you. Sir Amr, you mentioned multiple wire technique. You want to comment on that? If you still have a wire inside the dislodged stent.
The point is, when you are trying multiple wire techniques, sometimes you can enter in one of these part of the stent, maybe distally, maybe proximal, and this is one idea. So this is a point to try to get inside of this stent, especially if you have the wire outside, the stent outside the wire. Another point is sometimes when you are doing these multiple wires, you can use one of the small balloons that you can use to try to catch this stent. This is an option but different than snaring because it's like the same. You try to snare it, but in a different way.
Great.
You know, this is what I say. Complication done by a senior, and here they listen to learn. I mean, this is not to criticize anything, just to learn from this, not to happen in future. So when you come to complication analysis, from prediction, you can predict something going to happen with this kind of classification. Whatever you're going to use, either oversized balloon, you're going to use rotablation, because, you know, lithotripsy, you're going to have some complications. For me, the problem was in the distal left main, and we, of course, wanted to cover everything in LAD. I would have, you know, now, of course, very easy to say. I would have just, you know, done ballooning, then finish with DCB. I think for me is, at least my experience, been fine. For distal left main, I would have done something simple, as everyone said here, provisional, sequential, depends what the outcome will be. Because that's where the problem started. We blocked all the, side arteries.
Can I finish with this? Who, in all honesty, would consider wiring those diagonal or one of them before we proceed with PCI? Look at them. No significant osteal disease, they're not huge. I don't know if that would ever change anything.
The angiogram, please. Can you take us back to the angiogram?
This is the angiogram, I'm showing it.
Yeah, I cannot see it. I think the turning point in your case is when you decided to go for full metal jacket. I think if you did a hit and run, you might have got away with it. It's a difficult case. I commend your courage and your perseverance with it. Like, you did everything possible, but these things happen. But I wanted to know, why did you decide to go for a full metal jacket? Like, the lesion is not that long, and it would have been done with just a stenting where that branch is coming off and the left main.
So with IVUS, it showed very severe even after that second diagonal. It was very severe disease. Okay. Now, so just distal to that diagonal, okay. I thought it would be better actually to have, because you're going to be chasing yourself. And by the way, the problem happened not after the first or second stent, it's actually after the third stent. The one that you were proposing, just to do it up front.
Okay, Hamid, I think there is no, here we are trying to learn. I guess for everybody regarding the Lucas device, there is also some data regarding cardiac contusion with using it. So placing it correctly. So I don't know if any other places use it. We stopped using it, to tell you the truth, because of this fear of cardiac contusion. This is my pearls of wisdom here for everybody.
Abdurrahman, before Dr.
Briefly, so in hindsight, people will always think of something different. Like going first, I would just state proximal that I would have done. I think seeing the images will do differently. I know what you're talking about this helplessness feeling when you get cases like that. Today I'm discussing a case where you get helpless and what you can do about helplessness. So hopefully we can shed some light on that. As for the Lucas 3, the one currently not available in the Middle East, there's two devices that are radiolucent everywhere except for the compressor or the piston, and Lucas and Autopulse is there. There is evidence of some cardiac contusion, but the only machine that gives you a negative decompression, actually decompress, and that's the only with it. To run CPR and trying to do cath, unfortunately, we have to deal with this Lucas machine.
Hamid, thank you for very brave presentation, and I'm sorry for your feeling at that time. I know how that's tough, really. My question to you now, I'm sure after this procedures, you did brainstorming. What should happen, what shouldn't happen? So can you tell us now, if you can travel back on time, what you could change, what you will do, you didn't do, or the opposite?
So to tell you the truth, lots of reflection and looking back at the case. Now, this case, the guy was in good shape after his initial presentation, very smooth, although complicated even to the right, but the outcome was good. And losing him actually coming for elective, even if it's high risk, and ejection fraction was good. I think the aggressive preparation, actually, I have probably dissected, not dissected, just from the aggressive preparation of the lesion. I just created a milieu where you have so much debris just waiting to be flushed away. Rather than going actually all the way distal, for some reason, I just decided to go after I put the stent into side branches. And literally transform the whole thing into a malignant no reflow. You know, we think about no reflow, with the flow you don't see it going, but this is no reflow. You have no microvascular, done. So again, the troubling thing about this case is it could happen again. I mean, you cannot forego preparation. I think stepwise, would you go shorter? Would it make a difference? Honestly, I don't know. Thinking back, if I had the same case again, well, there's nothing. Shorter stent, yeah, we always aim for it, okay? But should not be at the expense of good, landing zone for the stent. So I cannot honestly wrap my head around that, Protection, that's probably the only thing. But every now and then, it's not, big diagonal to be safe. So again, it's perplexing to me, to say the least.
Okay, for the sake of time, yeah, okay, Naif, sorry. Naif, then Dr. Amr.
Which cases, a hybrid approach will be a better option, especially in those patients with peripheral artery disease. Maybe minimally invasive lima, followed by PCI to RCA will be a good alternative. I know it's unpredictable, no reflow, but I think short stenting or focal stenting for such a patient will be a good option. Thank you very much.
Just a quick comment, and the point is sometimes you have a small stent. When you are putting a small stent, 2.5 in the LAD, sometimes it may be a cause, maybe because sometimes it goes. But the point is, you need to wire if you have you have two diagonals. One of them is most important, big one. You can put a wire. I think I'm thinking retrogradely, so you can put a wire in one of the diagonal may be helpful. And I think to have it short procedure, because you have a left main, so you need to cover the left main first and just stay, and I think you can go out of the procedure. The point is, when you have multiple stents and you have not good, do you check the ECT is good, okay, also? This is a very important point because sometimes the heparin is not working, and maybe this is the cause.
Great. Hamid would like to congratulate you and thank you in multiple situations. You accept a patient that have been turned down by the surgeon. Congratulate you for trying to give him the best of the BCI to have the best outcome. And finally, congratulate you for being strong and brave to present him and us here in the complication. A great case, great discussion. So now we'll move to our next presentation and last session.